Okay. Good morning, everyone. Thanks again for your patience. I very much appreciate it. I'm Larry Boris, Executive Director of the National Association for Workplace Healthcare. And I'm pleased to have uh, our great speakers and members today, David Hines from Metro Nashville School District and Allison Zucker from the City of Davenport joining us. This is our first Monday roundtable. Today it's on for public employers. The roundtable is one of our efforts for those who may or may not be more involved in our organization. The National Association for Workplace Healthcare, which was formerly the National Association of Worksite Health Centers, is a nonprofit organization of employers and unions, hospital systems, clinic vendors, consultants, and everybody else who've focused or involved in on-site, near-site, mobile, and virtual health centers, as well as direct contracting for medical services for your covered populations. We have a variety of programs and services and research that's available to our members and to others who are involved with our organization. So please visit our website at www.nawhc.org to learn more about the organization. As I said, this is one of many programs. We do two programs a month. We have a roundtable the first Monday, and then we have a webinar. So the webinar this month is on value-driven healthcare solutions, a whole variety of activities and relating to what we term as value-driven healthcare. We also have our annual forum, April 8th and 9th. That'll be in person in St. Louis. We hope you can all attend that. And we have special pricing for our members and those who are interested in attending. And there's another program on worksite health centers in June in Chicago. And again, we can provide some information on that. Now, our roundtable format's a little bit different than our typical webinars. What I'm going to do is go around the table this morning before we start and ask everyone, just give us your name and title and your organization. Then we're going to have a presentation by each of the speakers. And then we're going to go around the table again, and I'll ask each of you for any comments or questions, shared experiences, knowledge, anything you want to share or learn about relating to public employers running worksite centers or direct contracting for your facilities. This session will be recorded, and so everyone on the call will get a copy of the discussion. And with that, let me just introduce our speakers again. Allison Zucker, Benefits and Occupational Health Manager at the City of Davenport, Iowa, and David Hines, Executive Director of Employee Benefits, Metro Nashville Public Schools in Nashville, Tennessee. So with that, Allie, why don't you start and give us a little background on yourself and the organization. But again, as I said, we're going to go around the table. So I'm going to call out your name, and if you'll just, again, give me a little bit about your organization and where you're from. So Tim Newman, you start off with you, Tim.
Hi, I'm a physician on the Medical Advisory Council for NAWOC and interested in this subject from that standpoint. And so an active participant with the NAWOC.
Great, thank you. Christy Patterson. Christy, introduce yourself, please.
Good morning. I'm Christy Patterson, Executive Director of a multi-employer pool serving schools in Northern California, and we have two near-site primary care practices as part of that program.
Thank you, Christy. Kendall Rosenmeyer, Kesdal, introduce yourself, please.
Hi, yep. Kendra Rosemeyer, General Manager with Achieve Health. We have direct primary care clinics in Minnesota and Wisconsin. So always interested to hear more about what everybody else is doing and best practices. So thanks for your time today.
Great, thank you. Jen Maniscalco from HHC. Jen?
Morning. Yes, I'm Jen Maniscalco, and I am with AAAHC. Looking forward to this presentation today.
Thank you. Angela Deem. Angela, introduce yourself, please.
Good morning. I'm Angela Dean, Manager of Occupational Health for Sarasota County Government. I'm a nurse, and we have two nurse practitioners that work for us. Currently, we do OC Health, but we're expanding into primary care as the employer providing those services to the employees.
Thank you. Shel Kalala. Shel, introduce yourself, please.
Yes, hi there. I'm Shel Killawa. So I work for Huntington Ingalls Industries. We go by HII. So we are a defense contractor. And we have two fully functional on-sites with primary care, PT, a whole slew of support. And then we also have a quick care And yeah, we are just always looking for additional support and learning. I oversee all of our well-being and health on benefits.
Great, thank you. Gary Ward. Gary, introduce yourself, please. Take yourself off mute. Gary?
Hi, I'm Gary Wald. I'm the soon-to-be retired Chief Operating Officer of Milliman Plurtum. We are a clinical data, real-time clinical data information and educational service, providing data in real time to on-site clinics and self-insured employers.
Thank you very much. Kenley Gaddis. Kenley, introduce yourself, please.
Hi, I'm Kenley Gaddis. I work for Build Farms Corporation in Northeast Georgia. I'm the Group Benefits Coordinator here. I also have
Stephanie Cordell. We are self-funded insurance with about 5,000 employees, and we do operate 3 primary care facilities and 2 pharmacies. So
Great.
just here to learn more.
Great, thank you very much. Martha Shepard. Martha, introduce yourself, please.
Martha Shepard, Medical Director for Vanderbilt Health at Metro Nashville Public Schools, and also on the Physician Advisory Council.
Great, thank you very much. Michelle Balmaceda. Michelle, introduce yourself.
Hi, good afternoon, everyone. My name is Michelle Balmaceda. I'm a physician executive here in Charlotte, North Carolina for Novant Health. Just interested in learning from everyone's perspectives with regards to building sustainable workflows. So I'm here attending that seminar. Thank you.
Thank you. Melanie Small. Melanie, introduce yourself.
Good morning. I am Melanie Small. I work for Intermed, which is a primary care company located in Maine, and we have some on-site and near-site clinics, and we are just started working with a local municipality, so thought it would be good to learn.
Great, thank you. Nicole Strash. Nicole, introduce yourself, please.
Good morning. My name is Nicole Strock, and I work with Christy Patterson. I'm the Employee Benefits Manager for our multi-employer pool of school districts in Northern California.
Thank you. Rob Goldsmith. Got Rob, introduce yourself, please. Rob, take yourself off mute. Introduce yourself.
Hi, I'm sorry. I'm Rob Goldsmith. I'm the president of MBS Healthcare Group. We do consulting on companies looking to expand their on-site healthcare offerings.
Great. Thank you very much. All right, at this time, we're going to have a brief overview with David and Allie, and then we'll go into some questions. So, Allie, let's just start out with you.
Yeah. Hi, everybody. I'm Allie Zerker. I am with the city of Davenport, Iowa. And for the city, I oversee the employee benefits division as well as the risk management division. Within the risk management division, we have occupational health. So that's really what applies here, is our OC health and our employee benefits. So a little bit about the city of Davenport. We are the 3rd largest city in Iowa. We have about 110,000 residents in the city. We have 8 wards. We have 10 aldermen because we have 1 for each ward and then 2 at large. We are located about halfway between Chicago and Des Moines. And we are known for the Bic 7 road race, if you've ever heard of that. But we also are the only place where the Mississippi River does not run north-south, it runs east-west. So, and we are the only large city on the river that has embraced the flooding. So we don't have a flood wall or anything. We've kind of designed our downtown to just allow for the flooding every year. So that's a little bit about the city, which matters a lot in my line of work. It might not seem like it does, but for those of you that work with municipalities, you know that the city as an employer, what the city is and what they do and how the council, the priorities that the council sets, affect everyone a lot, even if they don't directly. Kind of getting their ear matters. So the city as an employer, if you want to go to the next slide. The city as an employer, we have over 800 full-time employees, 300 part-time, over 300 part-time, and over 300 seasonal employees. We have over 2,400 lives covered on the city's employee benefits plan. We have 7 unique employee groups, 6 of which are bargaining units. And 3 of those units can have some pretty strong bargaining rights to get into specifics with benefits. And on the OC Health side, our public safety here, they don't follow our traditional work comp. All of their disability work-related injuries are governed. Work comp here is governed by something called Chapter 85. But for public safety, it is a totally different beast with totally different rules under Chapter 410 and 411. So that adds a little uniqueness. We have 14 departments, and all of it, that is a variety of different employees, right? So when we're thinking about whether it be our employee benefits or work-related health care, so think your functional screens, your post-offer exams, your annual physicals, those types of things. We have pretty varied employees. So we employ anyone from an accountant to a firefighter to a police officer to a librarian to someone working at the water pollution control plant. So it is a wide variety of employees that we need to be considering. In order to meet the needs of all of those different groups, we've really taken on kind of a total wellness approach. And the pillars for that platform are really, we have a very rich and affordable health plan. We incorporate on-site wellness programs. We have, in addition to the on-site wellness programs, we have fitness programs. So employees can meet with personal trainers here on site up to 2 times a month. We also offer pretty rich financial health and financial wellness services. We have financial advisors come on site once a month that employees can meet with. And yeah, they can talk about the benefits that are offered by the city, but those financial advisors can advise them on any area of their life. And we try to take a pretty proactive approach with that. If an employee is going through, a hard FMLA situation, for example, if they're caretaking for an adult, a parent, an aging parent or something, and they start sharing things about the financial strain it may be taking, or if we have an employee that's off on an injury for our Chapter 85 injuries, they're only getting 70% of their wages. A lot of our employees, they need the full 100%, and they may count on overtime. So how can we not kind of walk the talk and incorporate that financial health and wellness into these other areas and kind of feed them out like little tributaries? We have a lot of direct provider contracts, both on the personal side and on the healthcare, the occupational health side. And then we have an on-site occupational health program, which is currently it's an on-site nurse program. Our main thing as a city, you go ahead, Larry, you're doing good. I'm not catching up quite. Our main focus is how can we contain costs, but without compromising care, and even enriching the care that we're giving people and enriching the benefit options, but controlling those costs. So how we do that is we've gotten pretty creative and innovative with our cost containment strategies. As a municipality, we have to get creative often because every organization has competing priorities. But a municipality, we're governed by a board that is elected officials, right? They're city council members. They're not experts in this field, largely. And their priorities are for the residents of the city. Oftentimes, they don't even consider that we are an employer. So there's a lot of education that has to happen. So we've gotten pretty creative. Some of our cost containment initiatives have been a ton of direct provider contracts. We've actually created a little network of independent providers that do some bundled pricing, and it's outcomes based. So we've met directly with these local providers, independent providers, surgical centers, rehab facilities, those types of things, think elective procedures, and allowed the providers to set their price for their bundle. So let's say you need a total knee replacement. That bundle is going to include all of your appointments leading up, the cost of the knee replacement. It's going to include all the durable medical equipment and let's say 6 PT appointments. They kind of figure out what their average is. And if that was an amount, let's say they were going to bill our standard insurance plan 80 grand for that, they would negotiate it down to what, 50, and that employee would pay their out of pocket. And the plan would pay, let's say their out of pocket's $1,000, the plan would pay 49. We've allowed these independent providers to negotiate their own price. We will pay it within 7 to 10 days. And we're getting those knee replacements for $30,000. If an employee needs an additional knee replacement after that, or there's any sort of follow-up, it's outcomes based. So that provider has to, they eat the cost of that. So we've partnered with our consultants on this, and it has been absolutely fantastic. The plan has saved about $2 million since we went live with it. We piloted it for about 8 months and got great feedback. We also are constantly reviewing our stop loss strategy, looking at some creative measures, looking at your attachment points, but also kind of doing these longer contracts and looking at premium refunds. We've done some creative things with steering people. With those union contracts, we don't typically not allow someone to go to a specific pharmacy. Instead, we incentivize them to go to pharmacies that do cost less. So we've waived the copay at some pharmacies, and there's been significant cost savings from that. So more access to preventive screenings, mail order pharmacy. And then our main focus though, so we've done all of these things. We've seen great results. We've had great buy-in, but we weren't really maximizing our on-site program. It was at its full capacity and we had much more need. So what the city is doing now is we are expanding our on-site program to a true clinic. And I have Larry and this great group of people that I've probably heard speak that are listening to me now to thank for this. So our clinic is going to really focus, the buy-in here is on the occupational health care, because in the state of Iowa, that's where we can direct care. So we've kind of proven the concept on occupational health. So the pre-employment, the work-related injuries, fitness for duties. We're going to be staffing this with a nurse practitioner full-time, an RN, and a medical assistant all full-time. And then we're also going to have a PT there for 20 hours a week at the beginning. And really it's going to be looking at work-related injuries, fitness for duty, annual physicals, those types of things. We are at the same time, we're launching it with like kind of a convenient care lens, with a goal of potentially expanding it to primary care one day. So whoever said that they are doing that now, I would love to pick your brain eventually on that. There isn't really an appetite and leadership right now, but I am very hopeful in the future we can get there. This is a picture I took last week. We are literally constructing this right now. So I hope to be able to give you guys some updates. But there have been a lot of struggles as well. And I would say the biggest struggles that we have run into, making it make sense to all of us in this room is easy, right? Because we all know, we get it. I would say gaining and maintaining buy-in from all of the different groups that you need is the biggest challenge. You have leadership changes. As a municipality, we have 2-year terms. So I had a bunch of buy-in with one group, and then what do you know, they're out the door and I got to get it again and I have to train them all. Acknowledge the knowledge gap. I had some leadership, we've had some leadership changes from the employment side as well. And sometimes in there, I've had leadership that didn't want to break it down to the basics for council who ultimately needed to approve this. Don't assume people get it. What we're suggesting here, whether it be a creative cost containment strategy, direct contracts, I mean, building a doctor's office as an employer. That's what we're suggesting. It sounds crazy to people if they don't get it. So like remembering that it makes so much sense to all of us. We totally get it. Don't assume they do, and break it down to the why. Also figure out why it matters to different people. Those were some of the barriers too. How can I tie it to the priorities the council has? Because they want better roads, right? That's what they ran on. How can I tie it to that? Well, you want better roads? Let's look at the injuries and the amount of time off the people that fix the roads have, whether it be for an annual physical, to keep their CDL, an injury, all of these things. How can I tie it, the time that they're spending over here, the extended time off? How can I tie that to their priorities? We had to do some staff displacement. That was kind of a little bit of a barrier because we had to negotiate with the union about that. Specifically in the public sector, look at your calendar cycles, whether it be for the city council approvals or your fiscal year or whatever it is. Like if I propose this now, whether you're the employer proposing it to the city council, or if you're a consultant that's trying to get someone's business or that's trying to propose a new idea, ask for help with those things because you don't want to get shot down just because the timing is all wrong. So looking at those kind of things, and then not getting lost in the weeds. People, once they do start to get it, or you're trying to get them on board, they all have an opinion and they all want to go, well, what are the hours going to be? It doesn't matter right now. Not being afraid to go like, well, we aren't there yet. And not engaging in that, but finding a polite way to kind of back yourself out. Because if you get drug into the weeds and lost in the weeds, you're probably going to end up losing the buy-in that you're trying so hard to get. And the last thing, I just love to share this picture, the total worker health kind of holistic wellness approach that we've taken. One of the little things we've done is we bring these therapy dogs on site to different departments. Each department gets one visit a month. And like, how cool is it to see these cops that have been through the ringer? We've had national cases with a little girl murdered, and there are cops in this office or in this picture that really saw some super dark days through that, that are just smiling. So I think if you're looking for a place to start, look for free things. These dogs, it's a local group. It's a local group that we bring on, and it's free, and it brings everyone so much joy. So like, don't be afraid to start with the little things. It can be intimidating if you start thinking too big.
Great. Thanks so much. David, let me turn it over to you. Can you pull up your slides?
I shall do my best.
If not, let me know. I think Diana might be able to do that if you can't.
There. Are you seeing my slide?
I am not.
Well, evidently that's not working. Then let me try.
Let's try. All right,
Okay.
Diana, you can try that. Otherwise, Diana, can you put yours up? All right, David, why don't you just talk from it and we'll try to get
there
that up
she is.
working it.
It looks like Diana has us there, but I can go ahead and start up here.
Yeah, go ahead. Why don't you go ahead?
Anyway, MNPS. For those that haven't been to Nashville lately, you have not been to Nashville. It's a different, changed, vibrant area. I take care of the teachers in Nashville, Tennessee. One of the things you'll find if you work with government, there's a lot of things that don't make sense necessarily. It's just government. You just adjust it and move on type thing. But in our Metro charter, we actually have a clause that says Metro Employee Benefit Board takes care of all employees except for those with a teacher's license or a teacher's pension, basically. So there was this separation that was put into place. And so basically I take care of the teachers. We have about 6,500 active teachers. about 4,000 retirees. You put that together with their dependents, about 18,000 covered lives. So can we go to the next slide, please? Anyway, I showed up at the school board about 18 years ago, Gary. I'm going to bore your tagline. I'm also soon to be retired. So I'm getting close to the end here at the end of April, actually, to retire and see what's next in life type situation. But I've been with the school board for all those years. And another thing within government, there's different entities have different ways of governing and taking care of folks. When it comes to the school board, we have our benefits set up to report to the Board of Trust. That trust is about half union, half management. Oh, perfect. And basically, that's who I report to. When I showed up 18 years ago, I sat down with a very lengthy document that I thought was going to be my mission and objectives. And it really has been. And this is kind of a summary sheet of some of the stuff that I put in that document. I've learned not to get too wordy now and try to keep everything on 1 to 2 8.5 by 11s, one typically two the most type situation, and try to stick with the highlights. But I get them to reassert every year to make sure I'm still in sync with them, our basic mission, and that's this whole thing about to look beyond the impact, to look beyond healthcare costs alone to the impact of poor health on the total health and productivity paradigm, knowing that healthy employees are more productive employees. Healthy teachers are more productive teachers. They're in the classroom more. They can handle the grief that's given to them in that classroom more type situation, and therefore we help them show up and we help them engage and we help them stay engaged, basically. And that's what we look at our mission and we'll reassert that. Next slide, please. To fulfill that strategy, to fulfill those that basic goals, these are our pillars. One, we have one simple low-cost health plan. I tell everybody, I give them choice in healthcare, take it or leave it. It's one plan, take it or leave it. I think I have a $300 deductible, about $2,500 out-of-pocket maximums. I have a lot of zero cost share. I have low co-payments when it comes to physician services. And pharmacy is still at a very low co-share amount. I just do co-shares. I don't get into co-insurance. We have a data warehouse that's been key to our success and to keep our success going, because without data, you can't validate what you're doing is right or wrong or indifferent type situation. So we get all our claims data from our carrier. We get all our pharmacy data from them as well. But on top of that, we look at other things that we want to integrate in. If we have a point solution, we'll get a feed from them so we can identify the folks on the point solution and outcomes. When it comes to our on-site medical, we get an EMR feed. We have lab values and different things being filled in. LabCorp and Quest, we get lab values from them. We also take our payroll and we drop it into our data warehouse. That way I know when people are showing up at work, who they are, where they're working. We've also added in race and ethnicity data from our HR feed, but anything we think is value. Another thing is health risk assessment data drops in there too. So it helps us get this larger, well-rounded view of folks. And because remember, we're looking beyond the cost of healthcare alone to that overall integrated paradigm. What's going on with their productivity? Are they showing up for work? Are they not showing up for work? Are we retaining them? We can take a look at that as well. We're very heavy into value-based benefits, believe in removing physical and financial obstacles to care. Basically, our clinics is one of the big things where we achieve that area, and the fact that we give away our care at our clinics, primary care plus, and I'll get into that a little bit more, to both our employees and our dependents at no charge. We also have a strong focus on population health. One of the better things I did a few years ago, and I think brought Martha Shepard on as our medical director and told her, says she doesn't see patients per se. Her patients is the population as a whole. And she works diligently on trying to improve our overall focus on the health and productivity of our population. Lately, she's been very engaged in lifestyle medicine, because if you look at what we're doing nowadays with all the point solutions that are basically trying to improve people's lifestyle, whether it's nutrition, whether it's movement, whatever, that should be incorporated, not addended to our overall care patterns within our clinic. Another thing that's very key on lifestyle on our approach is we are a patient-centered medical home. In fact, AAAHC certified patient-centered medical home, as we take time to look at quality initiatives, close gaps in cares, and really take that extra step on focusing in on the population. And then, of course, on-site health centers. We started, no, that's fine, go ahead. This is where we started in 2009. We took 5 classroom portables, we remodeled them, we set them across Nashville with the concept of 15 minutes from any work site, no more than a 15-minute wait. As I mentioned, free primary care. We use family nurse practitioners and physician assistants to basically staff these clinics. Inside the classroom portable, you can actually get 4 exam rooms, a very small waiting room, a very nice handicapped restroom, and a lab, and an office for the NPs. And that's how we started. We spent about $500,000 in 2009 with the remodeling of the portables, plus fixing up an operations center out of one of our existing buildings. Next slide. What we did was positive enough and profitable enough that we basically would beat our cost projections every year and developed out reserves. In fact, the RAND Corporation came in many years ago and did a study on us, comparing our total healthcare spend of those attached to our clinics versus those attached to primary care providers in the community. And they showed basically we were saving about $62 per member per month for those attached to our health centers versus attached to the community-based physicians in that total healthcare spend. That we were investing more on primary care on the front end, but we were getting better returns on the back end. And we update that fairly constantly and keep an eye on that metrics. And it's still a savings today. One of the things that we see so much in there, one of our key areas of savings is the fact that we have fewer high dollar claimants for those attached to our clinics. And the ones that we do have are lesser in intensity, doesn't cost as much. But anyway, with all that said, at that point, the study was about $2.6 million a year in savings that we were seeing. And that was helping increase our reserves. 2017, we opened up our first brick and mortar facility. It's 26,000 square feet. Inside there, you have a full range of practice. You have primary care, you have health coaching, you have psychiatric nurse practitioners, we have physical therapy, chiropractic, and acupuncture. We have a full Kroger pharmacy. We have meeting rooms, we have a coffee bar, we have a fitness facility. And so we launched what was our first integrated wellness center. And it's still our only integrated wellness center, but we still dream, even post-retirement, I'll keep dreaming of that second space that we already have designated and trying to get to build. So hopefully, now that we're getting past the post-COVID yipes, we'll get something going soon. Next slide, please. And this is where we are today. When you look at our medical staff, and we use Vanderbilt Health to basically manage and staff our clinics. And we branded our clinics Vanderbilt Health at MNPS. We used to be the MNPS Employee and Family Health Centers. We thought this was a better way to get this separation and reduce people's fear of lack of privacy. As you can see, 18 family nurse practitioners, 3 behavioral health. I think I'm up to 4 now. I'm up to 2.5 chiropractors, 4 physical therapists, patient support services. So we actually have navigation support, our nursing staff, our pharmacists, our fitness staff. And that's where we've gotten to today. Oh, one more slide. In this slide, I just want to show one of the things that we've seen now on the backside of this. I mentioned we have race and ethnicity, but we also have mapped out our social determinants of health in areas that are high risk or low risk when it comes to whether it's a health or desert or not. And basically half our member population lives in areas of high risk. by the grace of God, so are our clinics are either in or contiguous to. And so we've been able to help out, especially those minority populations that are more likely to be in those high-risk areas. Have got an extra bump from what we do. That's it.
Well, that's great. Thanks very much. So, as I said earlier, what we're going to do is just go around the table and I'm going to call out your name. And if you have a question or comment or experience you want to share or information, please do so. So let's start out with Christy Patterson, Butte Schools. Christy, comments or questions?
I don't have a specific question. I just got a little bit of professional jealousy. I'm excited how you've expanded yours. Our challenge is we are a multi-employer pool rather than the employer. And so we serve 16 different employers in our county. And so forcing down that culture is a little bit hard sometimes, but great job. Congratulations.
Christy, are those all public employers or is there a mix of public?
All school districts, yeah.
All school districts.
So,
Okay.
lots of the same mission.
Great, thank you. Angela Deem, Angela, comments or questions?
I do. This was great. Thank you. My question is, since we're just starting out and I'm starting to explore this on my own, without very little support. And so I'm trying to understand the insurance implications, like to the HSA, and whether there has to be a summary plan description that has to be reported if you're the employer offering your employees a free on-site clinic. I don't know if anyone has any advice on that.
You know, oh, go ahead, please.
Oh, no, you go ahead, David.
I was going to say our approach is we have a self-funded plan. We actually pay for the clinics out of the health plan premiums. And so it's not a separate entity that sits alone. And we just, that way we also control the co-payments. Another thing that we do is we force our carrier, our vendor, basically to file claims for reimbursement. Then we just true up the difference every month. Because what I wanted to do is, like myself, I'm not a teacher. I'm on the Metro Employee Health Plan. I go to our clinics, they will file a claim on my behalf, and then basically Metro government has given us permission to waive the cost share. So my benefit is the same as the teacher's benefit inside the clinic walls.
So for us, so we're self-funded and the clinic, so we're not running, there's no cost to anyone that is going to be using the clinic. And we are not running claims through the insurance at all. So we're paying an hourly rate for the providers. And there is no fee for service. So we're going to have documented like fee for service with zero charges so that we can see the cost savings, but we're not billing to insurance. We don't have an HSA, so I do know there's some additional like caveats for that part of it. But since ours is tied to employment specifically, so it's open to all employees, even our seasonals. If they have a sinus infection, they can stop in and go be seen. But so we are not making any summary plan document changes, except for we are going to put something in there because spouses that are on the plan adult dependents that are on the plan can utilize it, but there were no implications for our plan, but we're not a high deductible plan. So I would say chat with, we had our consultants help us with that a little bit, but get creative with how you're funding it. And like I said, we're not charging it literally anyone, anything for the insurance plan.
Yeah, typically among our members, particularly the private employers, if you offer more than first aid, triage, and wellness, it's a separate ERISA plan that the employers create. It is, and if they offer an HSA to their populations, the IRS code requires you to charge a fair market value fee, which could be as little as $10, as much as the Medicare provider rate, whatever you come up with. And anyone that's getting services beyond first aid, triage, and wellness and preventive care has to pay this fee. However, if you have a PPO population, you can charge nothing if you want to. The scope of the services is all based on what the employer wants to offer. Usually the clinic is under the umbrella of the health plan. so that any services outside of the clinic services being delivered there, when they refer out to other providers or services, that's billed to the plan. Usually the vendor or the hospital who's managing the clinic is contracted with the employer under a cost plus contract or a per member per month, some kind of capitated approach. So there's no fee for service involved with this typically. All right, let's move along. Shell Kalawa, Shell, any comments or questions?
So I don't have any questions, but I did want to say, Allison, that I feel you with the leadership change. We had one with our CEO previously who stood up our health centers. We stood them up because of feedback. So as I had mentioned at the top of the call, I work for a defense contractor. We have a shipyard in Mississippi, a shipyard in Virginia, and then we have a tech division, which is a distributed population. And our shipyard in Mississippi is in a healthcare desert, extreme healthcare desert. And so we stood up our health center there. We do not include OCHealth. We do have occupational health clinics at both shipyards. In those, we do a direct hire. We manage those, but our health centers are done completely differently. And we have an amazing vendor, QuadMed, that does our direct employer clinics. But anyway, so we had a CEO that helped us stand them up, and he was obviously all in and wanted value. And we certainly do have ROI, and we have VOI, and we have saved money, and our patient outcomes are better than community. However, proving that to him was a completely different exercise than with our new CEO, who is certainly amazing, but he comes up from the finance side. And so it's been a very different experience. And then so yes, it is very different. And there, as you mentioned, there's certainly a different, there's a knowledge gap. There is, he sees it differently. And so it's been a struggle to do some things, and as far as growth and different things like that. So I feel for you as far as the every 2 years situation. That sounds amazing that you deal with that on a regular basis. So I feel for you. But I do hope that you move forward, or that you're able to, because the direct care, the primary care, there really is a lot of value. The access to care, like everything that you were talking about, really can improve for your employees, and you can get those roads built like you were talking about. So I really hope that you can make that happen.
Great, thanks very much for the comment. Denise and Kenley from Fielddale Farms, any comments or questions?
Hi, this is Kenley. I did not, but thanks.
Go ahead.
Go ahead, Denise.
Oh, I did have a question. I was curious about with the discount, with the direct contracting, with your first speaker about the knee replacements. If you are self-administering your claims, or how are you doing that if you have a vendor, a TPA?
Allison, you're on mute.
That's a great question. No, we are certainly not self-administering that. I have no interest in any of that. We have a TPA for that. It is Nomi Health is our TPA for that. And they have been absolutely wonderful, and you can customize things with them, which is always nice.
Very good. Very good. So you're not competing. Our issue when we've looked at that is that we're competing with our TPA for their own discounts. That's the pushback that you would get, or undermining the networking that they're doing. And we're with one of the big three, so you can understand that.
Yep. So we are very specifically and strategically not with one of the big three because of that. But we're with UMR, who, it's a subsidiary of one of the big ones. And we've worked with them on that. But I think the biggest thing in this industry is having honest conversations, not being afraid to have honest conversations, being kind and just generally in life, being a good person, like being a kind person and working with them. We had honest conversations with them. We said, here's the situation we're in. Like, how can we make this work together? Because otherwise, like, we might have to go find a smaller TPA. Like, we're really happy with you guys, but other TPAs will administer this, and it's not the route we want to go. But like, what can you do to help us? And so we were able to work it out.
Very good, very good. We've done a lot of direct contracting for like colonoscopies, MRIs, things like that, but nothing on the surgical level.
Radiology, I haven't gotten there yet, and I am just chomping at the bit.
Great job, though. Doing a great job.
Let me just add, I'm with one of the big threes. I put in our RFPs when we put our bids out. We have to put things out to bid every 5 years. One of the things I put in there was a confirmation of support where they had to sign to say they would support our initiatives. Part of that was direct to provider payments. We have a lot of value-based bundles that we work with that kind of go over a wide gamut. Cigna signed it. Cigna is supporting our claims. Basically, will go from these different contractors that we're with directly to Cigna, and they'll adjudicate the claims.
Very good. Very good.
Thank you very much. Michelle Barcetta. Michelle, any comments or questions?
Hi, thank you. This is a very well thought out presentation. Allison or David, if you both had to start over, would you focus behind on demonstrating cost savings, reducing lost time, or building cultural buy-in first to get your RFPs across, and why?
I would say cultural buy-in first. One of the things I ran into when I was here is they had approved the concept of on-site medical through the insurance trust, but they never pushed it forward. When I went to push it forward, I ran into a finance director for Metro government who was going in a total different direction, more of a high deductible health plan type person type situation, and didn't like me giving away care, basically. I think was the way he saw it. So he shut me down for years. It took an election to where he had to, elections have consequences. The mayor was gone, he was gone. The new finance director didn't have the same bias. So we were able to move forward at that point. But if you can't get people to use the clinic, if you can't get the buy-in, if you can't get it up, you'll never get to part 2 and part 3 of showing your ROI. And it takes a while before you actually see an ROI. It took us about 3 years before we started actually seeing an ROI mature out.
Good point. Thank you for that. Allison, if you had any thoughts, thank you.
I would say, yes, I agree, David, but I also think like more so than cultural buy-in, because I think between those three, you have to figure out who are you trying to convince, because you might have a leader and a decision maker that doesn't give a shit, sorry, about your people in the cultural buy-in. Like, exactly. And so you're going to be fighting a losing battle if that's what you're like, no, there's no financial benefit that I can prove, but everyone wants it. Like, there are leaders that don't care. I think, but David is right that is the most important thing if you can't get them. But I think where you start with that is having good relationships and knowing you having through your employees or through someone, like knowing what, that you have the good relationships. And even if you don't have like the buy-in quite yet with them, you know, you can get there. I know that can be so taken out of context, but like sometimes people don't know what they want. And how I got to this a little bit was I have monthly meetings with union leadership and then meetings with kind of stakeholder groups, and all the things they were asking for. None of it was let's have an on-site clinic, but things were people are gone from work too long. It takes too long to be drug tested. I waited in the clinic for 4 hours and never got seen, so I left. Well, I can't go get my blood drawn for my medication because I work weird hours, whatever it is. And so then this became the answer. So I think it matters on who you're trying to sell.
Perfect. That makes a lot of sense because like I said, you have different stakeholders and sometimes kind of educating the account executives that go through the communities and having this conversation it's kind of pulling teeth because we don't know who they are and what they want. And so hearing from your side, it probably, and I think the answer is it depends. I don't know. I think that's what where you're getting into. And I appreciate that because we've been fighting that losing battle. Is like, do we need to just a buy-in or do we need to show cost savings? And it's a lot of paperwork and a lot of, work from their side. And sometimes it just doesn't translate to something that, hey, I can even get to an RFP. You know what I'm saying? So thank you for that.
Sure, and now it can help you come up with proving the value of your center or the value of centers in general. So take a look and we can help you with that. Nicole Strach, Nicole, comments or questions?
Nothing in particular, no, but I just wanted to thank the panelists and everyone else's questions. This is all really informative and thought-provoking and helpful to hear what others are doing.
Thank you. Melanie Small, any comments or questions?
No, thank you. I appreciate the conversation.
All right. Tim Newman, any comments or questions?
I always appreciate hearing the outstanding model that David and Martha have developed, the most comprehensive integrated model of population healthcare in the United States. And David minimizes his trial and tribulation to get there, but he's set forth an amazing administrative model. And then Martha has put everything health into a population health management. So if you have questions and are able to ever visit or need assistance, they've been through every twist and turn to develop that center. Allison, I think you're doing an amazing job of putting together from the ground up and developing a very good center that meets the need of your people. And so it's fun to see the contrast between, I'll call a smaller model and a big model, but I appreciate both of your presentations and what you're doing to promote on-site health centers.
Thank you, Tim. Gary Wald, Gary, any comments or questions?
I do. Dave, I had a question for David. David, in your pop health, are you segmenting cohorts?
As in what cohorts are you looking for?
Well, the things that will cost the company money. What cohorts have you identified? Are you segmenting your population by cohort? I ask because we've talked a little bit about our product, which is CareFlow IQ, which is a total patient view beyond the EHR, and that can identify and segment cohorts as you might need them and know where the money's being spent, tracking care gaps, tracking program successes. When you put a program in place to address a diabetes or some other cohort, are you tracking that beyond the EHR? Because that's what the CareFlow IQ can do, and what the result is that we help those programs be more effective at a lower cost. So I didn't know if you were doing that.
To the point that, it's like high dollar claimants, inpatient cases, we're monitoring them going in and out. We do have a lot of different programs around different disease states, diabetes being one. Another one, we just finished up some work with Cylinder Health Point Solution on GI health. Just got published on that one. We're in I think it's Joan, we just came back out into on that, showing a positive ROI and also a reduction in absenteeism. But, a better person to have that discussion with would be Martha, especially since I am the soon to be retired one. So, as you are as well. So,
all right. Well, maybe we'll have a cocktail and say goodbye to each other.
Sounds good.
Larry's dog ate his.
Yeah, I think he's Larry. You're
Sorry,
right.
my dog is going nuts here.
Dog ate
Jen Maniscalco, Jen, you want comments or questions?
Thank you, Larry. Fellow dog lover here. So completely understand. Just a thank you. Thank you, David, for the kind words for AAAHC. We do appreciate it and look forward to at least seeing you at NAWAC and bidding you farewell, at least for this part. Thank you so much.
Thank you.
Agreed. Martha Shepard, Martha, any comments or questions? Okay, I think I've touched base with everyone. I want to thank those who stayed on to the end. Of course, I want to thank Allie and David for great presentations. This will be recorded, and we'll send a copy of the link to everyone out there. Thanks, everyone, and have a good week. Stay comfortable, stay safe. Enjoy yourself. Bye-bye.
Bye now.